I'm going to show you how to perform a prone pelvic mobilization. You want to start out with some traction. Because they're in prone, they can't do a bridge to get their pelvis in a more neutral position, so you want to perform a little bit of bilateral lower extremity traction. Once you have that traction and you're hoping that the pelvis is in a neutral position as possible, you're going to place your thumbs on the bilateral PSIS and then your index fingers wrap around to the front to the bilateral ASIS. Once you're there, you're going to use your assessment skills to determine if maybe there's a unilateral upslip of one of the innominants, maybe there is a posterior or anterior rotation of the innominant, maybe you determine that both sides need treatment, or maybe you decide only one side needs treatment. I have determined on this kiddo that his right PSIS is superior or more caudal than the left PSIS, so I want to bring that PSIS down. So I'm going to get into a position to perform that treatment. And so what that looks like is I'm going to find the iliac crest or the border of the iliac crest, and I'm going to place either heel of my hand either above or below, dependent on which direction I want to encourage that innominate to move. And I want to bring the right PSIS down, so I'm going to put the heel of my hand above that right iliac crest, and I want to bring relative the left innominate up so that we get more balance and symmetry. So my left heel of my hand is below the left iliac crest, and I'm going to perform grades 3 or 4 mobilizations to those innominates and then reassess and continue to treat as needed. Outside of that treatment, you can do some work prior to performing that grade 3 or 4 mobilization. So on this kiddo, I'm assessing her pelvis the same way. And before I'm going to find that there's a slight rotation of the right innominate anteriorly. That right PSIS is slightly superior. And before I do that manipulation, I'm going to work on some fascial mobility. So maybe with a kiddo, you find that there is some asymmetric or bilateral limited movement of the fascia, of the connective tissue, of the skin. Maybe you perform some skin mobility prior to that mobilization that you're going to perform at the iliac crest. And so that's what I'm demonstrating here, is that the benefit of getting the tissue surrounding the innominate to be more mobile. And then once that tissue has that flexibility to move, the innominate might be more accepting of a mobilization that you want to perform to get that pelvis back more in a neutral position. This is an example of, after assessment, I have found the right PSIS to be posterior to the left PSIS, so the right innominate has moved posteriorly compared to the left, and so I'm performing a posterior anterior mobilization, so my force is directed in an anterior position through that PSIS. This is another example of fascial mobility or connective tissue mobility and muscular mobility in that prone position that you might want to perform prior to the mobilization. I want to emphasize going to the tissue's end range and then moving in lateral or diagonal movements at that end range position. You get really great results with improved tissue mobility when you're combining the skills that you have maybe for techniques that are similar to scar mobility. And finally, let's talk about infants for a second. Infants are super wiggly. They might not be in a state that they want to accept the manual work that you're performing. They might be crying, they might be wiggly, they're not going to really tolerate or compromise with you as you move through this. You have to adjust. So with your assessment and then with your treatment, you're going to want to go with their body. We like to recommend starting in supine. Just the more information you have, the better, and a supine position might give you some different information or more information than a prone position. So there might be some benefit to flipping an infant over to do some supine assessment. Once you have that assessment, the manual techniques for treatment are going to look exactly the same. Your magnitude is, of course, going to be smaller. And so with this little guy, I have found the left PSIS to be more caudal than the right, so more superior than the right. So I want to bring that left side down. So the heels of my hands are going to be above on the left and below on the right of the iliac crest. I'm going to perform that mobilization, the grade 3-4. This is demonstrating some fascial mobility that you would probably want to do before that manipulation, the mobilization that you're performing. And this is just showing some reassessment. I'm moving with his body. This is another PA mobilization, so the force is directed from the posterior to the anterior direction. I'm still not seeing quite as much movement, and so I think what I'm going to do, yes, is I'm going to move into some mobility work to see if I can help him release some tension along the left side of his body, thinking about the baby as a whole body, and so what is his cervical rotation doing to that. And there are lots of techniques to use with infants to help release tension, chronic tension that they might be demonstrating on a regular basis. Using those skills to work on that mobility, the flexibility to get their body in a more relaxed, calm, accepting state and balanced state so that you can perform mobilizations to their pelvis that maybe are more long-standing and effective.